Dear professors and colleagues, good afternoon. My name is Liu Jingjing. I'm from the ultrasound department of First Affiliated Hospital of Seoul University. Today, I want to share with you an interesting ultrasound case. The title is "The Winding Mountain Road Leads to the secluded place to find the truth, a stubborn abscess." First of all, let's take a look at the patient's brief medical history. A 43-year-old woman with right low back swelling for more than half a year, felt pain, and diagnosed subcutaneous abscess. She underwent puncture and drainage once ago and intubation 1 month after operation. Recently, she still feels unwell to come our hospital. The patient underwent an appendectomy 9 years ago, partial intestine resection for intestinal polyps 7 years ago. Physical examination showed 2 surgical scars, local swelling and tenderness in the right low back. The first ultrasound examination shows that the long strip ankle area in the subcutaneous muscular layer of the low back was irregular in shape. The boundary was not clear, and the internal sound transmission was poor. Color Doppler flow imaging showed that there was no obvious blood flow signal inside and around the lesion. The initial diagnosis conclusion is abscess. The patient went to the other hospital for re-examination. The conclusion is consistent. Clinicians carried out anti-infective treatment. However, about 3 weeks later, the patient's symptoms was not relieved, and the patient was re-examined by ultrasound. The results showing that the scope of the lesion increased and the depth became deeper. And the scan also found a new mixed echo area in the right inguinal area as shown in the finger. In order to make a clear diagnosis, we performed contrast enhanced ultrasound. Sonovil 2 milliliter was injected through the vein. There was no enhancement, and angular high enhancement could be seen at the edge of the contrast, which cultivates a typical image of abscess. When combined with the patient's blood routine examination, the size of the infection was further confirmed. In order to relieve the patient's symptoms, we performed ultrasound-guided puncture and drainage again. We observed that the drainage fluid is yellowish-brown, muddy and thick, smelling, probably 100 milliliter. The treatment could have come to an end, but the cause of the stubborn abscess was never found. So we combined the whole treatment process to want to find the answer. The history of 2 operations has entranced our attention. Then maybe the answer. We thought of intracavity contrast enhanced ultrasound. Used Sonovil dilute 5 milliliter to inject into the drainage tube to observe a dynamic process. We were pleasantly surprised to find a slender continuous fistula extending from the lesion to the small intestine. This stubborn abscess may come from the intestines. We then used X-ray sinus angiography to show that the contrast agent intended the right lower abdominal small intestine. The patient then underwent surgery, and the technology to confirm the diagnosis of intestinal fistula and confirm our diagnosis. Yes, we are right. After the accident, we reviewed the relevant acknowledge of intestinal fistula. It refers to the abnormal passage between the intestine and other organs, or abdominal cavity and outside the abdominal wall. There are many causes in intestinal fistula. The most common cause is infection. Accounting for about 75% to 85%. Clinical manifestation include pruritus, abdominal fistula, surrounding skin evolved, and symptomatic symptoms. Among them, infection is the main cause of death in the treatment. In face of the intestinal fistula, there are many aspects we can do, and the most important thing is effective flushing, and the surgery is needed if necessary. Through the effort of the medical profession, the fatality rate has dropped significantly to 5.3 to 21.3%. To sum up, we realize that as an ultrasound doctor, we must closely combine the medical history, treat problems with clinical thinking. Secondly, use ultrasound in-hand ultrasound to broaden the field of vision. Finally, the use of imaging techniques to avoid delaying the disease. That's all. Thanks for listening.
Thanks, Dr. Liu Jingjing, for our presentation. Now we'd like to have Dr. Yang Wei to comment, please.
Thank you. It's a very interesting case report. By injecting contrast agent into the drainage tube and follow the flow of contrast agent, the doctor can find the fistula extend from the lesion to the intestinal, and then find out the reason for the abscess. I think this case shows the new direction of application of contrast ultrasound in abdominal disease. And in this case, my question is, you showed us many ultrasound pictures, but no abdominal CT or MRI. I would like to know if injection contrast agent played a better role in identifying the source of abscess than CT in this area. What is your opinion?
This case, we just do ultrasound and X-ray. The patient once do a CT half once a year. She treat as the abscess. Don't find the it comes from the intestine. So this time we didn't do CT. And this time the X-ray sinus ultrography to prove it's from the intestine. So this time we don't do it to CT. Because the X-ray sinus angiography is the gold diagnosis technology.
So you had a CT first, but didn't find the reason, and then you do the injection of contrast agent, and you found the reason.
Yes.
Okay, thank you. So this means sometimes ultrasound play better role than the abdominal CT in this case.
Yes.
Thank you.
We are great.
Thanks, Dr. Yang Wei and Dr. Liu Jingjing.